So I would like to introduce then our speaker for today, and Professor Martin Henscher will talk about health economics. And Martin has over 30 years of experience in health economics, planning and financing, gained in the UK, Australia, Africa, Europe, and Central Asia. Before joining the University Menzies Institute, he was the Deputy Director of Deakin Health Economics and Associate Professor of Health Systems Financing and Organization in Deakin's University's Institute for Health Transformation. Previously, Martin was the European Union consultant in health economics in the South African National Department of Health. He is a senior economic advisor in the Department of Health in England and a senior executive in the Tasmania Department of Health. Martin is a member of the South Australia Health Performance Council and a board member of Glenview Community Services. And finally, but not least, Martin is a volunteer search and rescue specialist with the Tasmanian State Emergency Service. Welcome, Martin.
Thank you, Peter. There we go. I'll put my slides up. There we go. How's that?
Great. Yep.
Good. Fantastic. Well, thank you for that introduction, Peter. So yes, I'm going to give a talk really, which is a bit of a teaser for some of the content that we'll be doing in the new course next year. And we're going to start the first unit in that health economics specialization is actually going to be a subject we're calling sustainable health economics, which is really this is kind of my specialist area, which is how can we apply health economics to the growing problems of sustainability in healthcare, both economic sustainability, but also the ecological, environmental sustainability of health and healthcare in the kind of the age of climate change, etc. So I'm going to talk a little bit about that. Peter's done our acknowledgement of country, but I'm going to start with a little bit of history. When we watch the news or read anything about the economy, people are always talking about growth. They mean how people are very concerned about how fast is the economy growing. We've become conditioned to think very much about growth. If we take a step back, for most of human history, there actually was no economic growth at all to the best extent that we can actually measure or estimate that from the statistics. Pretty much people's standards of living stayed very much the same for some thousands of years until sometime maybe in the 17th century, certainly by the 18th century in Europe, starting in Britain, but rapidly moving out to the rest of Europe, something fairly extraordinary happened. And the economy and economic activity transformed beyond all recognition. And for the last 250 years, let's say, the economy has grown at a rate that has been unprecedented in previous human history. So that now our economic activity is really thousands of times higher than it was at any other point in history. And again, as far as we can tell from historical statistics, something similar happened to human health around the same time, perhaps a little bit later than that economic transformation of the Industrial Revolution. It's very hard to get good data on life expectancy, but we do have data for the United Kingdom, which goes back to the 16th century. And you can see here, that's the long pink line, kind of pretty flatlined for a couple of hundred years. And then sometime maybe in the 1860s, 1870s, we see life expectancy in the UK starting inexorably to rise. If you look at the purple line, which is the world, later than in the UK, but the whole world has then followed that trajectory in the kind of last 100 to 150 years. So there's no doubt that the increase in life expectancy is directly related to the explosion of economic growth that facilitated all kinds of things. Most crucially, it allowed dramatic reductions in childhood mortality. So for most of human history, nearly 50% of children would be dead by the age of 15. That is now down to 4% globally, and a fraction of 1% in high-income countries like Australia. So there was a dramatic transformation in health too. And unsurprisingly, we also saw a dramatic transformation of healthcare. So before the Industrial Revolution, most healthcare pretty much looked like this. I love this painting of the surgeon in his very clean and well-maintained shed doing some surgery. And here are some contemporary surgeons using a robotic surgery or a surgery robot, I should say, in an environment kind of unthinkably different. If you put that surgeon from the 17th century into this operating theatre, he probably wouldn't even know what they were doing. He certainly wouldn't be able to contribute to it. Although, if we look at this picture of a hospital in Florence from the 16th century, interestingly, I think if you put one of the doctors from this Florentine hospital into a modern inpatient ward, they might not be able to do anything, but I think they would be able to spot that it was a hospital. So some things do stay the same. But what's really been going on here? Well, three things have been changing all at the same time. Technology, of course, professionalism and professionalization, and complexity. So here's the first Australian ambulance service from 1895. I fact-checked this photo because I saw that it had a telephone number, and I thought, hang on, did they have telephones in 1895? And indeed they did. The first public telephone service in New South Wales started in 1884. So here's the first Australian ambulance. And then here's one of our ambulance Tasmania Bell helicopters from today. So lots of differences here. The most obvious difference, of course, is the technology. Now, obviously, the difference between a helicopter and a horse and cart, but also crucially, the technology inside that helicopter, all the different healthcare equipment, consumables, etc., that mean that honestly, the in-flight paramedic on that helicopter can probably do quite a lot more than your average physician or surgeon in the 19th century could just on the helicopter, let alone at the hospital where the helicopter is taking the patient to. But there's also been a total transformation in our workforce. So the paramedic working in that helicopter is now likely, for the particular role of being on the helicopter, is almost certainly going to have a master's in intensive care paramedicine. So they're not only a graduate, they've got a postgraduate qualification with enormous amounts of training, and they fit into a system filled with people with years and years of education and training and super specialization, so that our whole system is enormously more complex, more specialized, more full of moving parts than healthcare from 100, 200, 300 years ago. So that complexity, professionalization, and technology have been going up and up and up relentlessly. And so has something else, which is the sheer scale of healthcare. Now, this graph shows you United States healthcare spending as a share of gross domestic product. Now, gross domestic product is simply the size of the economy. And I'm showing you US data because really the US is the only country that we have reliable data for that really goes a long way back in time. So there's a study which has looked at Massachusetts, which estimates that in 1800, about 2% of Massachusetts' gross domestic product, 2% of the economy of that time, was devoted to health and medical care. By 2016, that was 18%. So 18% of the entire American economy, if you like, not strictly true, but as a simple approximation, 18 out of every $100 spent is being spent on healthcare in America. America is an extreme case, certainly, in how much it spends, but this shows you that kind of starting from such a small share now up to a massive share is actually not uncommon in the world. So imagine, in absolute terms, how much bigger 18% of America's current economy is from 2% of America's 1800 economy. It's enormous. It's almost impossible to get your head around how huge is that growth and that difference. But after those 250, 300 years of accelerating growth, we now have some nasty signs that we might be running into a bit of trouble. And in particular, that we are running into some external, mainly, but not only, environmental constraints. In the middle of this slide is the planetary boundaries framework. If you're not familiar with it, this is a system which has been developed to try to identify 9 critical areas of what they call planetary boundaries. So areas like climate change, like biodiversity loss, like ocean acidification, etc., where they can try and assess whether the Earth, the whole of humanity, is still in what they call a safe operating space, the green space, or whether we've actually moved into areas of high risk. And you can see in 6 of the 9 planetary boundaries here, we're now in what they're assessing to be a high risk or an increasing risk zone and outside the safe operating space. And we already see that. We see that in record temperatures every year. This past year, record monthly temperatures. We see that in increasing incidence of bushfires, natural disasters, flooding all around the world. We've been experiencing the flooding here, but all these extreme events simply are becoming more frequent. They are becoming larger in their scope. At the same time, we've just come out of a major pandemic, which people can argue about whether it's strictly related to planetary boundaries and biodiversity, etc., but some clear evidence that overall we are seeing more zoonotic transmission of diseases from animals to humans, which doesn't look good for the future. And we're now in an era of increasing conflict, increasing armed conflict, and very tragically, the last couple of years have seen more healthcare infrastructure destroyed than the preceding decade. So we're seeing lots of pressures building now across humanity. And think about that growth curve I showed you. What we're actually seeing is that economic growth globally is slowing down. So the rate of growth of the economy has got slower and slower every decade since the 1960s. So there's less economic growth, less rapid expansion of the economy. So what does all that mean? So one of the areas that I work in is a discipline called ecological economics. And ecological economics takes a perspective that is a bit different from what people might call traditional or orthodox neoclassical economics. So in neoclassical economics, which is really the model that most of today's economic policy is based upon, economists see the economy as the most important thing. There is a space for the natural world, which is essentially inside the economy. So if you look at this little chart, you have the economy, the big gray circle, and inside it, the green ecosystem. And economists agree that we need the natural environment. We need it because we dump waste and pollutants into the ecosystem, and from the ecosystem, we extract natural resources. And economists have a name for nature. It's called the natural resources sector. So it's literally, it's the part of the economy that we take natural resources from. So the founding father of ecological economics, a man named Herman Daly, had a really critical insight that this was actually completely the wrong way round, which is pretty obvious common sense, but for economists, that's not necessarily the way we like to think. So he had the insight clearly that the economy is a wholly owned subsidiary of the ecosystem. If there's no ecosystem, there's no economy. So the economy is a subset of nature. And yes, indeed, the economy draws resources, matter, energy, etc., from the ecosystem, and it dumps out matter and energy and heat as pollutants. And the economy delivers for people, it delivers economic services, all the goods and services that we use, but also so does nature. Nature delivers ecosystem services for humans, fresh air, fresh water, all the biodiversity we depend on. So Daly understood that the economy is a subset of the ecosystem. And he realized that for a long time, the economy was small enough that that was fine. We could extract resources and we could pollute, and that really the economy, the human economy, was actually not big enough to really, at scale, impact negatively on the natural world. But then, as the economy has grown and grown, and like, figuratively represented here, from the small economy to now the big economy, that progression of exponential growth that I showed you on the chart, eventually the human economy has now come to fill up the ecosystem. And we're now in what Daly described as a full world, where humans, our economic activities, our livestock, our farming, our resource extraction by deforestation, you name it, now takes up more and more and more of the natural world. And you see that in these incredible statistics about how, humans and our livestock are now more than 90% of the total biomass of all mammals on the planet Earth, for example. So we have literally filled up the world. And that raises the obvious problem of, well, once you start filling up the world, what happens when you get too big? And that, coming back to this planetary boundaries diagram, is the worrying conclusion that many ecological and planetary scientists are now really coming towards, is that precisely we have filled up the world, and we're actually pushing now, we've filled it up too much and pushing it into the danger zone in all of these planetary boundaries. Now, people are starting to think about that and the economics of that in different ways. And what a great way of thinking about this, which some of you might have come across, is by Kate Raworth, who has come up with the idea of the donut and donut economics. And her idea with donut economics is that humanity, and what she calls the safe and just space for humanity, is kind of like a donut, like the green donut here. In the middle, we have what she calls the social foundation, all these essential basic needs that humans have: food, water, good health, education, etc. And we want everybody on the earth to have their basic needs fulfilled. But on the other side, the other edge of the donut, is the ecological ceiling, beyond which we don't want to push too far, because that's then pushing us out into the danger zone. So things like climate change, ocean acidification, etc. So the idea of donut economics is, what is an economic system and a way of managing the economy that can keep us within that safe and just space where people have enough, but not too much, so that we're actually damaging our ecological future. And there's a great website here, which you can actually go and look up different countries where they have tried to estimate the donuts for different countries. So here on the left, I've got their estimates for Australia, and on the right is India. So if we look at Australia, in the middle, in that social foundation, a perfect run of blue there, which means for Australia, we are, in the way they've defined these basic needs, we are meeting the basic needs of our population fully. Yet we're doing so at quite extraordinary environmental cost, in that we're pushing out into many of the ecological planetary boundaries beyond our safe, or as a country, our fair share of those boundaries. On the other hand, India, you can see, is broadly within its ecological ceiling, except for, you might be able to see there's a tiny sliver of red on CO2 emissions. So India already just beginning to move slightly beyond what is actually safe for them in terms of carbon emissions. Their other ecological footprint still within probably their ecological ceiling, but quite a bit of red in their social foundation. So they're still not fully meeting the basic needs of many of their people. And India is a very long way from being the poorest country in the world. So that's very striking there, to contrast Australia with its great social foundation, but complete blowout on ecological impact with India. And so the kind of the mission that people working in donut economics and related areas is really, how can we meet humanity's basic needs without blowing past the planetary boundaries? And my work really is trying to apply these different perspectives, particularly perspectives from things like feminist economics and ecological economics, applying that to health and healthcare, which interestingly, not a lot of people have done. So I've been able to kind of be quite lucky with this choice of field and do some really interesting work and be one of the first people to be working here. And it's worth saying, conventional neoclassical economics, the definition of neoclassical economics is it's the study of the allocation of scarce resources among unlimited wants. So neoclassical economists, conventional economists would say resources are always scarce. So we're always having to make choices about how we allocate resources, but people's wants are unlimited. So people will always want more. So how can we allocate amongst people who always want more? Whereas feminist economists take a different view of what economics is. They see the economy as the social provisioning system, the way we organize resourcing for society, for how we meet our social needs or our needs as a society. And ecological economics goes a step further and talks about ecological economics is the study of the sustainable scale. So how big is the economy? The fair distribution, so how justly are resources distributed, and the efficient allocation, how efficiently are resources allocated of society's resources. So I'm trying to bring some of these different perspectives to bear on health economics. Health economics has conventionally been down in the bottom left corner as a neoclassical economics discipline. How can we kind of update health economics and make it fit for this future? So that's ecological economics, as I've said. So how much is enough and how much is too much is a question that neoclassical economists just don't ask. And what is the fair and just distribution, both within and between nations, is a critical question, which is beginning to be asked again in conventional economics, but which was off the agenda for many decades. We've always talked about efficient allocation, and we will talk about that in the Sustainable Health Economics course as well. But actually, if we're operating under serious ecological constraints, in fact, using our resources efficiently becomes even more important than it has been in the past. And Herman Daly, who I talked about with the full world, he kind of developed that more theoretically as a specific economic model. And he had this insight, really, which is as the economy grows, for a long time, the growing economy adds greater value, what economists call utility, the MU, marginal utility in this graph. So as the economy grows, for a long time, $1 of economic growth adds additional value to people. But then at the same time, that economy growing is causing bad things to happen. Most simply, pollution, greenhouse gas emissions, the obvious things we know. And there's a point at which those negatives start to outweigh the additional value of economic growth. And we move from economic growth to a period of what Daly called uneconomic growth, where the economy is still expanding, but it's actually giving us negative value. It's harming us more than it's benefiting us. And so an obvious sort of interpretation that many ecological economists bring is that we are probably already in a period of uneconomic growth. And that figures. If you think about, we're seeing many, many harms. We're seeing many health and social harms and woes growing even as our society becomes richer. And that would be consistent with us being in a time of uneconomic growth. That's just a slightly different way of showing that graph. So what does all this mean for healthcare? So I've said already that economic growth actually is slowing down, and that is a fact that over time, global economic growth is slowing. But healthcare, like that graph of the United States, this one includes a couple of other countries, the UK and Japan, healthcare is consuming a growing share of GDP over time. So even as the economy grows slower, healthcare is growing more and more as a total share of the economy. So the health sector is continuing to get bigger and bigger, and if you like, becoming a bigger and bigger portion of the total economic pie. And that's the same is absolutely true in Australia as it is in Japan and the UK. So healthcare expenditure in Australia is 10% of GDP. So it's 10% of the economy, and more than 10% of employment, more than 10% of everybody working in the Australian workforce works in healthcare. And what we also know is that, like almost every other good, healthcare displays what we call diminishing marginal returns. Now, that's a fancy economic way of saying, after a certain point, consuming more of something doesn't actually give you more value. It may actually cause you harm. And I mean, a trite sort of example of that is the first ice cream is very nice. The second ice cream is quite nice. The third ice cream, you're starting to feel a bit sick. The fourth ice cream, you throw up. But that relationship is true across many sectors, almost all goods. And we know it's actually true with healthcare. So at an individual level, we can get to a point where we're doing too many things for you. Think of polypharmacy. Think of just throwing more drugs at a patient beyond a certain point is actually going to do them more harm than good. So there is a sense in which we might need to worry about, can we have too much healthcare? And that's been a big focus of my work. And this chart just tries to show you how some of the factors in the wider economy come together to damage health, along with some of the things that we can do or not do within the healthcare system that themselves may actually result in health harms. So there's all kinds of things that in this growth economy, this economy maybe where we're actually seeing uneconomic growth, that overconsumption, consuming too much or consuming things that are bad for us, is causing all kinds of health damaging effects. So very obvious ones is smoking. We all thought smoking was on the way down. Now we've got vaping, haven't we? And most of the evidence really increasingly showing that vaping is probably as bad for you as smoking actual cigarettes. That's on the up. Alcohol related impacts, obesity, diet, physical activity, of course, pollution related illnesses. So for many decades, really, we all felt pretty comfortable that environmental health was improving, that pollution was being cleaned up. Now, honestly, when we look at things like critically climate change, but also things like plastics pollution, PFAS, these forever chemicals, various kinds of things, growing concern actually that we are probably going to see increases in pollution-related illnesses over coming years, and we're certainly going to see increasing health impacts of climate change. And then, of course, we've got everything going on in the world of addiction, social media, etc., leading into this mental health crisis unfolding in every high-income country across the world. So the wider economy, all of those things are linked to products which are being sold. That's then driving all these avoidable health harms, which of course make people sick, and they're then driven into the healthcare system. And in this chart, we call that failure demand for healthcare, because actually it's failure demand because that's preventable health harms that need never have happened. And then in the healthcare system, we sometimes don't help ourselves. When we get everything right, we give people necessary, beneficial care in a high quality way, and that's when we're giving them the right care. That's great. But sometimes we give people unnecessary care, non-beneficial care, so we can give them too many screening tests, we can do ineffective procedures like knee arthroscopies, etc. We can obviously, far too often, our care is not as high quality as it could be. So when we make errors and provide low quality care, we're causing harm to people. And in extreme cases, actually, things like the opioid epidemic in the US, which actually started with prescription drugs, remember, it became a kind of criminal operation, but it started with legal prescription drugs getting out of control, where unnecessary poor quality care can drive terrible harms. And then that drives people round in a circle. It drives them back into the healthcare system, where potentially we do even more bad stuff to them. So we need to think about breaking some of these cycles. That, again, is a big part of what my work is thinking about, whilst acknowledging that the healthcare system itself has a wide range of negative environmental impacts. So in Australia, we reckon that the healthcare system's probably responsible for about 7% of Australia's national greenhouse gas emissions, partly through the energy that we use, but also through the supply chains of all the products that we're using throughout our infrastructure. And we generate all kinds of other pollution. So we generate all kinds of nasties when we incinerate stuff. Directly, pharmaceuticals, 30 to 80% of most active ingredients in a pharmaceutical are passed directly through the human body and are excreted into the environment, where most of them are not removed by water treatment systems and end up in the natural environment. So there's a big job of work to do in the healthcare system to reduce our environmental footprint. And I'm leading work on how we can use health economics to hit that from both sides, both from the demand side and from the supply side. So on the demand side, how can we actually take action on all the social and commercial determinants of health, the left-hand part of that earlier box I showed you. How can we do better prevention within the healthcare system to stop people getting sick or coming back? How can we do really effective chronic disease management? How can we minimize poor quality care, overuse, etc., and bring all of those together to actually minimize the avoidable demand for healthcare, so that the people we're treating, as far as possible, are only those who really need healthcare. So we treat the minimum number of people for the maximum effect at the same time as we transform the infrastructure and the operation of the healthcare system itself so that it stops emitting greenhouse gases, so that we work out how to reduce some of the emissions of other kinds of pollutants, etc. So there's a whole load of work there. And then if we take a step back globally, come back to this question of how much is enough healthcare, we get some quite interesting results when we look globally at health status and healthcare across the different countries of the world. So this is some analysis from a paper that is coming out soon from my team in Lancet Planetary Health, where we looked at health expenditure per capita across the x-axis and what they call health-adjusted life expectancy. So that's a measure of life expectancy adjusted for the disability state of the years lived. And each dot or little square, more like here, is a country. And what you can see is that, to begin with, countries with very low levels of spending clustered at the left-hand side of the graph, you get a very rapid and big increase in health-adjusted life expectancy for really pretty much every extra dollar you spend. Spend more on healthcare in low-income countries, you will get big improvements in health outcomes. And then somewhere at a relatively low level, at a kind of lower, what we call lower middle income country level, that rate of increase starts to level off. And by the time we get up to the levels of spending that we see in European countries, particularly Southern European countries, spending more will definitely not get you better health outcomes, and possibly is associated even with worse outcomes. So there's some kind of sweet spot. Unfortunately, we're not clever enough yet to identify exactly where that is, but there's definitely a sense that you can spend too much on healthcare as a society, and that there are a number of societies who are around that point. And honestly, whilst we're not the worst offender, Australia probably is a bit past that optimal spending point already. Although that's not to say we couldn't spend that money a lot better. And here, this chart just actually tells you something about the global distribution of health expenditure in 2018. So in 2018, in the Democratic Republic of Congo, an inhabitant of DRC had $32 per capita spent on their healthcare on average. Now, actually, most of that will have been spent in the capital city on wealthier people, but on average, $32 per capita. Whereas in the US, the average spend per American was $10,500 per capita. So that's an extraordinary, many orders of magnitude difference. And 75% of the world's nations spent less than $1,131, which is around here or here, kind of not so far away from these beginning of the slowing down of health improvement relative to health expenditure. And whilst the data is a lot weaker, we can see something a bit similar happening with healthcare greenhouse gas emissions, and it's clearly not the case that emitting more carbon dioxide from your healthcare system is related to better healthcare outcomes. There's a sort of this turning point where at the bottom of the V, where beyond that point, these health systems have higher carbon emissions, but actually seem to have worse health outcomes than systems with lower carbon emissions. So again, some suggestion that there's a point of sufficiency or enough. And that takes us back to the donut here, this framing of sufficiency. How much is enough healthcare? How can we think about healthcare from this donut perspective? And really here, the challenge is most of the world's population remain far from having decent access to basic healthcare, but many of the richest quite probably spend too much on healthcare, and quite a bit of what is being spent is achieving only minimal benefit. So we might be in a space where if we could change that, we can bring in both directions people into the safe and just space. So how do we do that? And that's really my overriding interest in this work. So there's a lot of challenges here, and in the Sustainable Health Economics course, we'll try and get into some of these things, as well as a bit more technical economics analysis. But there's really interesting challenges here in healthcare systems. Each healthcare system is different. There's big cultural differences between countries, even between regions. Who owns healthcare providers makes a big difference. How many are private, how many are public, how are they owned, what are the incentives people have, lots of cultural factors and things going on. This big addiction we have to new technology in medicine as in everything else. We love the technology, we want it, more and more of it, but sometimes we end up adding in technology which is really not doing much for us, yet we see that technology is inevitable. We must have it. Equally, though, the critics, the ecological critics, would say our systems are not in good shape to face an inevitable post-growth future. That graph I showed you of slowing growth, that we must come back within the planetary boundary, but anyway, our growth is slowing. We just need to get used to it. So how can we actually turn our current fragile health systems to get them ready for a tougher post-growth future? And there are some really fascinating trade-offs for healthcare here. We all, I think, would like to see more local healthcare. We'd all really like to see sort of smaller scale, more human care. We all want to spend more time on, what some people call high touch caring for patients. Yet, how can we square that with ever more complex technologies, complex global supply chains that we saw in COVID were really not very secure, not very resilient? How can we act on these social and commercial determinants of health, which are driving so much poor health and distress, particularly the social and commercial determinants of poor mental health now? How can we get the benefits of sort of a less medicalized, less intensive care versus how can we use the potential promise of all these things like precision medicine, artificial intelligence, all of these amazing technologies? How can we manage them well so that we don't over-medicalize people? And how can we do that in a way that will work economically in a system in which the private sector is increasingly struggling, particularly in this country, struggling to maintain its profits and its viability, versus how can we maintain public systems in economies where growth is petering out? I'm really interested in, this challenging time of transition, about who's being utopian and romantic and who's actually being a bit blind to the reality of an old system passing and a new system coming into its place that we can't fully see yet. And I hope that in this Sustainable Health Economics course, you'll get a bit of a flavor of this. Then we'll be moving on in the specialization to do a couple more units, which will be a bit more applied and quantitative and focusing on more analytical methods. And they'll be in development over the coming months. So I hope that gives you a little bit of a flavor. I will make the slides available if anybody wants them, to get in touch with Michelle and Peter if anybody would like the slides.